Howdy. Hey, everyone. Aaron Boster here with the Ohio Health Center saying thanks for learning about MS with me. It's MS Awareness Month. And as you're well aware, I love getting online and talking to you guys on live stream. And I have decided to try to do it quite a bit this month. It's my goal to jump on as often as I can to take your questions, to interact, and to help raise MS awareness. So I've never logged on in the middle of the morning. I'm actually not at work today. I'm on a day where I'm doing some other things away from work, and I have an hour free, and I said, what the hey, let's jump online and see who's out there in the universe and who wants to talk about MS with me. So we've got 38 people that jumped online. This is kind of awesome. Matt's online. Hey, Matt. Howdy, Rick. Hello, Kim. Hello, Divine. Hey, Candy Duncan. It's good to see you. Vicky's online. Hello, Vicky. Hello, Diane. Hello, Sharon. Hello, Elizabeth. I've got Michelle online. Howdy do. Becky's here. Hey, Amber. It's good to see you. I've got a bunch of people from all over the place. I've got someone calling in from Dubai. As always, I love when you guys share with me where you're calling in from. So as you jump on the call, if you don't mind, type in where you're calling from. It's great to see folks from Indiana, from New York City, from Alberta, Canada, from San Antonio, Texas. This is the community that I love. You guys are amazing. And I really want to have a conversation with all of you about MS. Now, I've done a lot of Q&As recently. And if you guys have some questions in mind, throw them out at me. I would love to answer them live. Keep in mind, please, that I can't do personal diagnoses or treatment plans on the interwebs. I can't provide proper medical advice just by reading something that you write in the chat. So please make your questions sort of general. There's a couple things that I also wanted to discuss today with you guys and get your feedback. I have some questions about my channel. I want to get your impressions about a few things. I also wanted to talk a little bit today about cannabis and MS. But first, let's take a look at the questions. Candy writes in, is secondhand smoke bad for thyroid post-Lemtrada? What are the percentages of problems? So Candy asks a rather intelligent question about smoking in a specific drug in MS, Lemtrada. And so let me unpack that question. First off, people who smoke increase their risk to develop MS. And if you have a family member with MS, you're already at slight increased risk, and therefore smoking would be a really bad idea. It would increase the individual's risk to develop MS, and very clearly we don't want that. My second point is, if you already have MS, smoking speeds up your disease. You get worse faster. Some studies suggest upwards of 50% faster. And so if you think about it, smoking would be the best thing you could do to make yourself get worse. Now, this question is about a specific situation where someone with MS has received the medication Lemtrada, which is codenamed for alemtuzumab. Now, as I've talked about on my channel before, when you take Lemtrada, there are some unique risks. And one of the risks is for autoimmune thyroid, where after Lemtrada, about 41 to 43% of people will experience an autoimmune thyroid problem. That means that because of the treatment, it messes up their thyroid. And the peak incidence of that is typically about 3 years after your dose. And it's a risk that we monitor by getting laboratories every 3 months. Fortunately, if you develop a thyroid problem, they're relatively easy to treat. At Ohio Health, where I work, we have some amazing endocrinologists who are very at the ready and will help us adjust Synthroid and the like to help people that are having thyroid problems. So even though we've seen plenty of thyroid problems, I feel very confident and very comfortable managing them with my colleagues in endocrinology. Now, what happens after Lemtrada if you smoke a cigarette? Smoking cigarettes increases the thyroid risk by threefold. There's a crazy study done that looked at this. And what it found was after Lemtrada, MS patients that smoked increased the risk of getting a thyroid problem threefold. Now, if you do math and the risk is 41% and you multiply by 3, you're basically almost guaranteed to develop some thyroid problems. Now, that is a very, very scary statistic. And obviously, if you are a person with MS and you're contemplating Lemtrada, I really, really need you to not smoke. Because even though thyroid is easy to manage, you don't want to have a thyroid problem. That doesn't make it okay or make it cool. And if you're smoking, that risk skyrockets. Now, Candy's question has another layer of complexity. She says, well, what about if you have secondhand smoke? What if you're not smoking, but someone around you is smoking? And the reality is we don't have an answer. This hasn't been carefully studied. People with MS, with Limtrada, who are exposed to secondhand smoke. But I will borrow information from MS in general. Secondhand smoke to someone with MS is still bad for you. It's still breathing in smoke. It's still pro-inflammatory. It can still drive the disease faster. And so it stands to reason, at least logically, that exposure to secondhand smoke, someone with MS after Limtrada, would increase the risk. I would not recommend that someone with MS subject themselves to secondhand smoke if it can be avoided, because I don't want to find out that, in fact, that risk is really high. That was a great question, Candy. Thank you for asking it. I hope that helped. I've got, wow, I'm going to try to do a better job of tracking the questions this time, guys, so bear with me. I'm looking down because that's where my computer is, and I'm trying to make sure that I don't miss questions. I've got Robin from Princeton, New Jersey. Hello, how are you? I've got Kevin from Oregon. Carla from South Carolina is here. And I've got, I can't pronounce it, AVJ Kids from Long Island, New York, who writes, what do you think of high-dose biotin for PPMS? And so that's an excellent question. Let's try to tackle that. Biotin is a vitamin. It's B7. It's one of the B vitamins. And biotin is available over the counter at any drug food store, typically in 3 milligram pills. 3 milligrams of biotin is supposed to be great for your nails and your hair. Very clearly, I don't take biotin, as you can see. And so some people will take biotin because of thinning hair or because of brittle nails. There were a series of studies done looking at ultra high dose biotin, not 3 milligrams, but 300 milligrams. So that's a lot of biotin. And what they found is in a population of people with primary progressive MS, if you took biotin, it seemed to slow disability progression. Now, that's a really big deal to me because we've tried to slow PPMS with many, many drugs. We were able to do it with ocrelizumab in the Oratorio trial, but we failed with Copaxone. We failed with interferon. We failed with Gilenya. And the fact that a vitamin, B7, looks like, at least in this one study, to slow progression is a big deal. Now, I would love to see that trial repeated, but I'm very, very enamored with the result. There's a second trial that was done looking at ultra high dose biotin, and it suggested that in people with PPMS, biotin slowed brain shrinkage. As compared to being on placebo, the PPMS patients on biotin got their brain volume got smaller, slower. So it slowed brain atrophy. And that's amazing. Again, we're talking about a B vitamin. Now, I don't think that this biotin story is done yet. And very clearly, we need to repeat the studies so that we can make sure that what we found is solid. But biotin is very safe. Biotin really doesn't have a lot of side effects. And when you weigh the risk benefit, I think that it is reasonable with the supervision of your provider to consider taking biotin if you have progressive disease. Now, I am not telling you to go out and take 300 milligrams of biotin. That is not what I'm telling you. What I'm telling you is I'm enamored with the data, and I would absolutely talk to your MS provider about whether or not taking high-dose biotin might be a good idea. There's one important caveat. So this is very, very important. I need you to hear the next thing I'm going to say. When you take high-dose biotin, 300 milligrams a day, it can alter lab results. You're not abnormal, but when you do the test for certain blood tests, the blood tests are altered because of the biotin. It turns out that certain tests use biotin as part of the test, as part of the assay. And so if you have ultra high doses of biotin in your blood, it can change the result. This can be seen, for example, with thyroid. If you're taking high dose biotin and you get a thyroid test, it'll look weird. Your thyroid's actually okay. There's no problem with your thyroid, but it'll look like it's not okay because you have biotin on board. Likewise, if you're taking a screening test for hepatitis, it'll look like you have hepatitis B. The test will come back positive even though you don't because you're on the high-dose biotin. Also, troponins, which can be used to check for heart attack, can be altered. They could be normal looking when they're not. if you're on high-dose biotin. So what do you do about this? Well, number one, make sure that you've talked to your providers and that you have their blessing and their consent and they're on board for you to take biotin. Number two, make sure you tell your providers, I'm on biotin and I read it can change lab results. Number three, before you have a lab test, at least 3 days beforehand, stop biotin. Biotin leaves the body very quickly. And so a couple days off is all that you really need to have a normal blood test. I hope this helps answer your question. We definitely need more research on this topic, but it is really, really cool. You know what else is really cool, guys? There are 93 people that have jumped online. That's awesome. If you guys are having fun and enjoying this live stream, click that like button, the thumbs up at the bottom of the screen. Give me a thumbs up and let me know that you're digging this, because I've never done a live stream in the morning time like this, and it's pretty cool. Let's take another question. So I've got Patty Strickland. Hey, Dr. Boster, it's Patty from Florida. What do you think, what to do about copy and paste medical records? Haha. So Patty from Florida asks a very relevant question. When I was in training, we had paper charts. So when you saw a patient, they had a paper chart, and in the paper chart were these things called pieces of paper, and we used something called a pen, and we wrote on the paper. And then we would use something called a dictaphone, where we would take a phone and we would dictate the record. Today I saw Mrs. Smith. She's a 55-year-old woman with relapsing MS on disease-modifying therapy with blah, blah, blah. And today we discussed da-da-da. And that would be transcribed, and then a piece of paper would be put into the paper record. And I have to be honest with you, I really like that. Now, in the modern era, 2019, we don't have paper charts. We have electronic medical records. And electronic medical records have certain advantages. So if I need to send a prescription to the pharmacy, press a button, whoop, it goes to the pharmacy. If I want to send a letter to another doctor, whoop, it goes and sends a letter. But there are some disadvantages to the electronic medical record. And one of them is the copy-paste feature. If you copy an exam from someone, you could paste it into another person's exam. Or if you saw someone last time, you could copy what you wrote and paste it into a new note. Now, in and of itself, that's not bad. That's not evil, but it creates an opportunity for mistakes and risk. And so I think the answer to your question, Patty, is that we need to be diligent. We need to be precise and accurate, and we need to not cut too many corners. I'll share with you how I grapple with this. My team at Ohio Health uses an electronic medical record. It's called Epic. It's probably one of the more well-used electronic medical records. And when we write notes in clinic, we have templates. So we have a templated note where you have to fill in the blanks. And the template ensures that we're doing good medicine. For example, if someone is taking Gilenya, I want to make sure that they're up to date with their liver enzymes. And so in my note, it says patient is blank with lab testing. And then I'm forced to fill in up to date, they're behind, they're due for, they're current with their labs. And I can't close my note until I fill in that templated area. And so by doing this, I'm not copying and pasting, but instead the record is prompting me essentially to make sure that I cover all my bases. Copying and pasting is not something that I endorse. And I think that there's a risk that people can make mistakes, and that's not acceptable when you're dealing with documenting someone's health in a record. Great question. Thank you very much. We have 106 people online. This is awesome. I'm loving it. I've got 57 thumbs up. Please click that thumbs up button at the bottom of the screen if you're digging what we're doing right now. It's MS Awareness Month. I am online with you guys, answering your questions and loving life. Let's go to the next question. So I've got someone, Shaquille Gill, who's connecting from Trinidad. I wish I could visit you in Trinidad. That's on my bucket list. It's very nice to see you. Someone writes in, what are the dangers of getting a late diagnosis? So the later that you're diagnosed, the longer you've had MS without therapy. And the longer you go without therapy, the more neurological damage you can accrue, the more brain damage that you can accrue. And that sets a trajectory for the disease, which is not a good one. We want to diagnose people as quickly as possible so we can get them on medicine as quickly as possible so we can minimize early brain damage and we can set the trajectory of their disease at a slower decline, or hopefully halt things. A late diagnosis can be detrimental to the person long-term, and being diagnosed at an older age has similar issues. And so the goal is to identify MS as quickly as possible, diagnose as quickly as possible, start therapy as quickly as we can confirm the diagnosis. That's a great question. Thank you for asking. I've got Susie Q online, and Susie Q writes, what's your opinion about cannabis with MS? Do you advise against it? Susie Q, as some of you recall, last week, my institution put on a CME, a continuing medical education for providers taking care of folks with MS. And I gave one of the many lectures, and my lecture was on cannabis and multiple sclerosis. I tried to record it myself, and it didn't work very well. It has been professionally recorded, and I'm told I'm going to get a hold of that video, and I'm going to load it onto my YouTube channel. And so very soon you will have an hour formal lecture that I delivered in front of a group of about 200 folks on this topic. Also, some of you recall that last Saturday, we did a live patient program. Again, at Ohio Health, there was 8 lecturers. We had 170 patients in the room. We broadcast on Facebook. And again, I talked about cannabis and MS. Again, I tried to record it, this time off my phone directly onto YouTube, and it didn't work. So I have a lot to learn. But I will get a formal lecture uploaded onto my YouTube channel soon. I would like to answer your question. And I want to put guardrails on my answer. I'm not going to answer your question, Susie Q, as it relates to the history of cannabis in the United States. There's a really cool book called History of Cannabis. And if you haven't read it, it's fascinating. And it talks a lot about the politics and racism and systemic control and a lot of other crazy topics that are germane to the story of the history of cannabis. But that's not going to be part of my answer. I'm also not going to talk about the legalities of marijuana or medical marijuana. This is a very, very hot topic. It's a contentious topic, and it's constantly changing. And so where I live in the state of Ohio, we recently adopted a medical marijuana law. I've done a video on why I'm bothered by that medical marijuana law, and you can definitely check that out on my YouTube channel. But I'm not going to be talking about the ever-changing law and the legalization. What I want to talk about instead is the science behind the endocannabinoid system. And so let me start off by talking about that very briefly, and we'll kind of see where this takes us. The human body has a system called the endocannabinoid system, which has receptors that bind cannabinoids. Cannabinoids are chemicals that bind to these receptors. And many people don't know this, but our bodies make cannabinoids. We make our own cannabinoids that bind to these receptors. And this endocannabinoid system is involved in inflammation in the immune system. It's involved in metabolism. It's involved in appetite. It's involved in memory. It's involved in pain, and it's involved in movement. And so when our own body makes cannabinoids and it binds to our cannabinoid receptors, it can stimulate very different parts of the human body and augment or change these systems. There are 2 receptors. Well, no, there's many receptors in the endocannabinoid system. But the 2 receptors that I focused my learnings on were CB1 and CB2. CB1 is expressed in the brain. And when you stimulate CB1, it can create psychoactive effects, which is a doctor way of saying you get high. When you stimulate CB2, there are no receptors in the brain, and so you can't get psychoactive effects from stimulating CB2. Now, we can find cannabinoids in our body, but there's also other places to get cannabinoids. And some of you might not know, but you can make cannabinoids in a laboratory. There are synthetic cannabinoids. And there's actually FDA approved products, for example, Marinol, which is a synthetic oral cannabinoid that you can swallow. And then there's phytocannabinoids. And here's where you want to pay attention. Phytocannabinoids are from plants. And there's a plant called the cannabis plant, and it has over 100 phytocannabinoids in it. So this is a very, very biologically complex plant, the cannabis plant, and it has a bunch of phytocannabinoids. The 2 predominant phytocannabinoids are THC, which some of you may have heard of, and CBD. Now, THC binds to the CB1 receptor. The CB1 receptor is in the brain. And so THC can make you have psychoactive effects, or it can make you feel high. CBD, which binds to the CB2 receptor, does not bind in the brain. It does not have psychoactive effects, and you can't get high. THC is illegal in many states, and CBD is not, because CBD has no psychoactive properties. Presently, the most common way that people consume cannabis is by lighting it on fire and sucking in the smoke. So they combust it and they breathe it in. And it goes into the lungs and it crosses the alveolar cell membranes and gets in the bloodstream and circulates in the bloodstream and binds to these receptors. And we have not studied smoked cannabis almost at all in MS. So this leads me to my first point, Susie Q. We have not studied the benefits, risks, tolerability, efficacy of smoked ganja. We have not done that. And most of the research that's been done has not been in edible cannabis either, and it has not been in vaped cannabis either. The most data that we have comes from an oral mucosal spray, which is trade name Sativex, and it's not available in the United States outside of research. It's available in Canada, and it's available in UK for MS spasticity and pain. There is a paucity of research studying cannabinoids, phytocannabinoids, cannabis, and derivatives for its use in MS. And I share that with you not to tell you that it doesn't work, because anecdotally, I have lots of patients that tell me, hey, when I use this cannabis product, my pain is better, my spasticity is better, but the data is lacking. And when we study this, it's very, very interesting. And I'm going to focus on MS spasticity for a second. When we study MS spasticity and we look at all the different small studies that have been done, there's a theme. Well, there's three themes. Theme number one is cannabis is very well tolerated. The side effect profile of the cannabis products that were studied were very well tolerated by people with MS, which is good. The second thing is that subjectively, the human with MS who took in the cannabis product subjectively generally felt better. So when they ask them questions, hey, is your spasticity better? Hey, is your pain better? Typically they report, yes, it's better. But objective assessments of spasticity, tests like the Ashworth scale, which measure how stiff a limb is when it's being moved, do not show a benefit. And so what does that mean? Well, it could mean that our ability to study spasticity MS is limited. It could mean that we're not seeing a very robust effect. It could mean that we need more research. And so that's a quick answer as it relates to cannabis and MS. There's much more to say, Susie Q, but I hope this provides an introduction and certainly more to come. Thanks for the awesome question. So what do we have here? We have Kathy from Eastern PA. Hello, Kathy. I've got Linda online. Hello, Linda. It's good to see you from Centerville, Ohio. I hope you and your family are doing well. I've got Andrea, who writes, I recently went to the doctor, got a clean bill of health, no new lesions. Congratulations. That's fantastic. I think that we should celebrate when things go well. When you get an MRI and it shows no new spots, that's a hallelujah. When you are able to complete a milestone, graduation, promotion, marriage, new home, baby in the house, I think it's reasonable to celebrate. When you set a goal for yourself of being able to walk a mile and you accomplish it, we celebrate. And when you get a clean bill of health, that is cause for celebration. So this is MS Awareness Month, and I want us to be aware of how excited I am when I hear that people are doing well. That's awesome. Congratulations. Looking at more questions, I've got Shaquille Gill from the South Caribbean. Wow, that's really awesome. Kim Ball asks, can I ask, is there a link of pain in the neck and the back with lesions? So this is an interesting question. And Kim is calling in from Scotland, which is one of my favorite vacation spots. Scotland is one of the most gorgeous, idyllic environments I've ever seen. And I have very fond memories of driving and seeing what I call Highland fuzzy cows, those big cows with the big furry red fur, and they have the big horns. Those are cool. But that's not your question. The question had to do with back and neck pain and then lesions. Back and neck pain is normally not from MS. It's normally musculoskeletal, either problems with the bones, problems with the muscles, sometimes problems with the nerves that come out of the spinal cord that are being pinched. But it's not lined up as if you have a spine lesion and your neck hurts at that lesion. The structure of neuroanatomy is not like that. And so I'm not saying it's not possible, but generally speaking, when someone with MS has neck pain or low back pain, it's not directly from an MS lesion. Now, if you have an MS lesion that makes you walk funny, like you're limping and you're kind of, got a hitch in your giddy up, that puts pressure on your back, that puts pressure on your neck, that puts pressure on your joints in a way that it's not intended to. And over time, it can wear out those areas and it can cause secondary pain. It's musculoskeletal pain from poor gait mechanics because of MS. But directly, we normally don't see that. That was a great question. And thank you for tuning in from Scotland. There are 118 people. I am loving this. This is fantastic. I got 67 thumbs up. Can I get a few more thumbs up? Let's see if we can get 100 thumbs up while we're online today. Let's get some more questions going. So I've got Lo who's online. Any link between MS and hypothyroidism? Lo, it's nice to see you online. I hope that you and your family are doing well. And Lo asks, is there a link between MS and thyroid? And the answer is yes, actually. It appears that people with MS may be slightly at higher risk of having thyroid problems. Now, we know that if you have one autoimmune condition, and MS is an example, you're more likely to have a second autoimmune condition, and thyroid can be an example. But there does appear to be an interesting link between MS and thyroid. I think that it is very relevant to check someone's thyroid, because if your thyroid's out of whack, you can be exhausted, you can have motor fatigue, you can have heat insensitivity, you can have a lot of different symptoms that could be confused or confounded or exacerbate things going on with MS. So knowing what's going on with the thyroid allows us to ensure that we can cross that off our list. Excellent question. Britta is online. Britta, it's wonderful to see you. Britta is a wonderful human being. She was a bus driver before she had to retire. She's from Germany. She is practicing her English, and I adore her. Thank you so much for jumping online, Britta. I look forward to your comments when I see them. It warms my heart, and I hope that you're doing well. Verna gets online. She says, good morning from Nova Scotia. Boy, Nova Scotia is on my list. I would love to visit Nova Scotia. And she writes in signs of secondary progressive. How do you know when you've crossed over from relapsing remitting MS? And that's a great question. So there is a misunderstanding, in my opinion, about stages of MS. People talk about relapsing remitting MS as if it's stage 1, and then secondary progressive MS as if it's stage 2. And that's not true. And we think about it as if you go along in time and you have relapsing MS and there's a line in the sand and then you have secondary progressive MS. And it doesn't work like that. It's much more of a continuum. Early on in the disease process, the disease is largely characterized by periods of relative stability punctuated with attacks or relapses or exacerbations. They all mean the same thing. And then the person recovers from that attack, either fully or partially. And then they may have a period of time where they go along in, at least as best they can tell, they're not progressing. Now, if you fast forward 20, 30, 40 years into the future, the disease has a different flavor to it. Generally speaking, people have less attacks. They haven't had attacks in years, or they have them very infrequently compared to early on. But they manifest a slow progressive disability independent from attacks. And I have a video called What is MS Progression? So Verona, if you haven't checked that out, I would encourage you to check that out. You can look in, you can search in my YouTube channel, and there's a video on progression, which talks about this in some length. And it goes into the leaking pool model of MS. It's a model that I find very, very helpful for trying to understand progression and trying to understand secondary progressive MS. Now, the question is, how do you know if you've crossed over? And I hope that you're gleaming from this that there's no line in the sand. If you haven't had an MS attack in 5 or 10 years, and you have accrued a slow, steady decline in function over several years, particularly as it relates to strength, ambulation, leg strength, arm strength, and walking, then you may be in a progressive disease state. Now, it doesn't mean that you're not going to have an attack, because you still could. It's less likely statistically to have an attack, but it can occur. So I don't like the term secondary progressive MS because I think it gives the wrong sense of what's going on. If you've ever had an attack, you have a relapsing form of MS. And so it's fair to say a relapsing form of MS. And then we use qualifiers, a relapsing form of MS with progression. And that is a much more accurate description, in my opinion, because it's not cut and dry like stage 1 and stage 2. That was an awesome question. Thank you for asking it. There are 117 people online. That warms my heart. I've got 93 thumbs up. If you're jumping online, make sure you tell us where you're calling in from because I love seeing it. And hit that thumbs up like button. I want to see if I can push that number above 100. What else do we have going on? Thoughts about IVIG as a solo treatment. So Liddy MS95 asks about IVIG. IVIG is immunoglobulin. And so immunoglobulin is doctor word for antibodies. Literally, when people donate blood, they extract the antibodies out of the blood, they clean it, and they have a bag of human antibodies. And I'm talking hundreds of thousands of random antibodies. That's the IG when you say IVIG. Now, the IV explains that it's intravenously administered. So what we're doing here is we're hanging a bag of other people's antibodies, and we're mainlining it into your arm. We're filling your bloodstream with other people's antibodies. And the theory here is there's so many different antibodies, some of them will bind to your autoantibodies. So if this is your autoantibody and this is IVIG, when they bind, it makes them not function. So this is not functional and it falls out of solution. And so it's a way of neutralizing autoantibodies. Now, keep in mind that the MS involves the immune system, and there was the cellular immunity, that's like the T cell thing, and then there's the humoral immunity, that's the B cell thing, and the B cells make antibodies, and some of those antibodies are naughty, and they'll attack parts of you. And so when you give IVIG, you bind them up and pull them out of solution. IVIG works to treat MS, and there is strong evidence to suggest that IVIG is a treatment for MS. IVIG is probably not the most effective treatment. It is very, very expensive. And in the modern era, we don't use IVIG much anymore to treat MS. There was a time when we had very few medicines, and if people busted through those medicines, we would sometimes turn towards IVIG. But in the modern era, I don't have patients that really need to have IVIG monotherapy. Now, there are many other autoimmune conditions that we use IVIG for. I personally would much rather put someone with MS on one of the monoclonal antibodies because I think the data is more robust and they do a better job of treating MS, but it can be done. Thank you for that question. Looking along, what else do we have here? Sergio writes, I use CBD gummies and the pain goes down considerably, also to fall asleep. Well, Sergio, I think that's fantastic. CBD is not psychoactive. CBD is not an illegal substance. And although there is a lack of evidence, there's a lack of clinical trial research supporting the CBD, I believe you. If you eat a CBD gummy bear and it helps your pain, I think that's fantastic. And anecdotally, I think that's good stuff. I do think that we need better research studies so that we can prove the point, so that we can have a better sense of the science. But I think that the fact that you've discovered that CBD gummies help you is fantastic. I've got Darlene from Canada. Hello, Darlene. I've got Andrea online. I'm on Ocrevus so far, no side effects. Well, I'm very glad to hear that. Ocrevus is an infusion given in the vein. There's about a 30% chance that people may have an infusion reaction with the first infusion. After that, the risk goes down below 10%. In my experience using Ocrevus, it's very well tolerated, and I'm very happy to hear that it's tolerated for you too. Hey guys, we have 99 thumbs up. We did it. We have 100 thumbs up. Woo! That's fantastic. Thank you very much. I've got Rick from Yosemite National Park. What's up, Rick? I've got Beth Smith. Good morning, Dr. Boster. Well, good morning, Beth. I've got Jen Carter from the UK online. Jen, it's great to see you. Thank you very much for the kind Twitter post that you've made recently. I really appreciate it. I've got Heather Miller. I need to tell my cousin to quit smoking. Yeah, you do. You do need to tell your cousin to quit smoking. Smoking speeds up MS. Smoking also is bad for you for other reasons. But as it relates to MS, There's nothing that drives the disease faster. And so you are giving love to your cousin when you tell your cousin that you care about them and that you don't want them to get worse faster, and that quitting smoking can help them do that. So thank you for caring about your cousin, and I agree with you. Matt is online. I have smoked cannabis since before my diagnosis, and I've thrived. My question is pain between the shoulder blades. Is that considered the cervical spine? Could it be stress or just MS? Matt, pain between the shoulder blades is generally not because of spinal cord damage. Pain between the shoulder blades could be from a bunch of different things, including a bunch of muscles and bony structures back there, and it's worth having it checked out. Now, if you have occasion to have a thoracic MRI for MS, you have the bonus of being able to look at the structures in the back, and that may give you some insights. But definitely bring that to the attention of your provider, because that doesn't sound very pleasant. So Natalie Martin writes in. Natalie here from Los Angeles. Hello, Natalie. It's great to see you. Curious if Baclofen could be an injection versus a pill and a surgically implanted device that protrudes. So Natalie, thank you for joining in. You know, one of the advantages of doing this live stream at different times of the day is different groups of people from around the world can join in. When I do a live stream really early in the morning, the folks in Europe are in their midday, and so it gives them a chance to jump on. When I do a live stream at a different time during the day, the folks on the West Coast have woken up. And so thank you for joining us. I really appreciate it, Natalie. Now, Natalie talks about Baclofen, and Baclofen is like a neurotransmitter, GABA. When you have MS spasticity and your arm is tight and it spasms and it cramps up and it hurts, what's going on is that you don't have enough GABA. That's the stop neurotransmitter. And Baclofen is a pill of exogenous GABA. So you're giving yourself the stop neurotransmitter to loosen that arm up. And the problem is, taking Baclofen orally, very little gets to the spinal cord. When you put Baclofen pill in your mouth, amylase and lipase in the saliva dissolve some of it. Then it goes in the stomach, and the stomach acid dissolves a whole bunch of it. And then it goes in the bloodstream, and it circulates in the bloodstream, and it goes through the liver, and the liver pulls out over half of it. And so there's very little Baclofen left in the bloodstream. Then it's got to go from the bloodstream, and it's got to cross the blood-brain barrier. But there's a problem. The blood-brain barrier is made of fat. It's a lipid bilayer, so it's 2 layers of fat. Baclofen, the molecule, is called lipophilic. It likes fat, so it binds to the fat, and it doesn't cross over. And there's one study that suggests that when you swallow a pill of Baclofen, only 4% gets to your spinal cord. And so in order to get a therapeutic effect, you have to take a really, really high dose of Baclofen. And then you can have all these systemic side effects of fatigue and sedation and dizziness and confusion, and it's not good. And so sometimes the dose of oral Baclofen necessary to help spasticity would also make you sleep all day long. And that doesn't work. So there's another way of taking Baclofen, and it's one of my faves. It's a therapy that's been around for well over 35 years. It's an FDA-approved therapy for MS spasticity, among many other kinds, and it's called a Baclofen pump, or an intrathecal Baclofen pump. Now, this is a pump that has liquid Baclofen in it, and it's surgically implanted under your skin, and there's a tube called a catheter that goes from the pump into your thecal sac, not in the spinal cord, but in the sac the spinal cord sits in, and then it drips liquid Baclofen. And there's no amylase lipase, there's no stomach acid, there's no liver pass, and that doesn't have to cross the blood-brain barrier because we're putting it where it needs to go. Intrathecal Baclofen is a way, way better way of delivering Baclofen. And we have at our center at Ohio Health probably 170 people with MS that have Baclofen pumps, and they benefit from it. It's an amazing therapy. I think it's transformative for some people. It involves a lot of careful monitoring, and you have to know what you're doing as a clinician. But if you know what you're doing, it can be really wonderful. I have several videos on my channel about Baclofen pumps. I have videos that talk about the anatomy of the pump. I have videos on who's the right candidate. And so if you haven't checked those out yet, I certainly would do that, Natalie. Thank you for asking the question. Let's look at another question. I've got someone whose name is Woo-oo-noo. Who-oo-noo. That's kind of a fun handle. Please talk about the gut in MS. Since a bout of C. diff, I get nauseated and vomit on antibiotics. All right. So there's several things about the gut in MS. And yes, I have a video talking about the gut and the microbiome. So it turns out that The microbiome are a bunch of bacteria and other organisms that live inside of us, and they live sort of synergistically with us. They're content, we're content, and most of them live in the gut. And there's something in MS called dysbiosis. Dysbiosis means that the populations of bacteria aren't the right ones. And we think that this can influence the immune system. Now, we know that it can influence the immune system in gut diseases like colitis. But there's some very interesting studies suggesting that people with MS have dysbiosis. They have the wrong kinds of bacteria in their gut, and maybe that influences their MS. There's a theory that if we could replace the microbiome with healthy bacteria, that we might be able to influence the immune system for the better. Now, this science has not been worked out, and you may have seen these studies of fecal transplants. So fecal transplants is where you're ingesting someone else's feces in a capsule, so you're not tasting it. And the goal here is to replace the gut bacteria with different gut bacteria. And that's very much a research thing. I am not suggesting that you eat poop, but I am suggesting that it's fascinating research. We also have probiotics, and probiotics you can purchase. They're available without a prescription, and it's a bunch of colonies of bacteria. Here's the problem. We don't know which bacteria are the good bacteria. We can't tell you, you need to have this kind of bacteria, or you need to have that kind of bacteria. And so the research still needs to be done. It's a fascinating area. And maybe one day in the near future, we will alter MS by altering the gut flora, by altering the microbiome, and by addressing dysbiosis. Now, separate from that, people with MS can have slow gut motility. And it's very common that people with MS have constipation. And this can become a major problem. I have a video on my channel where I talk about what I call bowel hygiene, which is behavioral techniques to help you move your bowels and to help you deal with constipation. And if you are suffering from constipation, I would check that out because there's some great tips and tricks that can help you with that. I'm going to move on and stop talking about the gut and poop for a moment or two. There's 117 people online. We've been doing this now for 41 minutes. We have 109 likes. It is MS Awareness Month. We are bringing MS awareness. We are bringing MS education. We are bringing energy, and we are bringing empowerment to people with MS. All of you online are participating in this process. I am loving it, and I'm committed to jumping online multiple times this month during MS Awareness Month to answer your questions and chit chat with you about MS. Let's keep on keeping on and look at our next question. Maggie May is online. Hello, Maggie May. Maggie May is fantastic. I love your participation in this channel. I love your comments. Thank you very much. I enjoy seeing you on Twitter. Wonderful surprise to see a live chat. I'm going to listen while I pack for spring break. Woo! I'm excited that you're going on spring break. I hope that you're going somewhere warm, and I hope that there's a beach and that there's an ocean and maybe an adult beverage. Have a great spring break. I've got Inga Franklin that writes in. Ooh, this thing just fritzed. It jumped around a little bit, guys. I'm trying to find where I was, but I'll just jump in over here. Kathleen Roman writes, what do you think of LDN? So LDN is low-dose naltrexone. And naltrexone is a drug used to reverse opioids. So when you have opioids on board, if you give naltrexone, you can block those receptors, and it can help with opioid addiction, or it can help block opioids. Low-dose naltrexone is a dose that's very low. It's a very small dose of naltrexone. And there is some anecdotal discussion that low-dose naltrexone may have some benefit in MS. I think that the data is about zero. I think that there's almost no science supporting the use of low-dose naltrexone for MS. That doesn't mean it doesn't work. That just means there's no science for it. I joke that whoever invented this idea, I want to hire as a marketer, because it seems like every patient asks me about low-dose naltrexone, and yet there's a profound positive clinical trial data to support its use. That being said, low-dose naltrexone is safe, and it's typically not that expensive. And so I have 3 rules when people want to consider a non-traditional medicine. It can't be too expensive, and low-dose naltrexone is not. It can't be dangerous, and low-dose naltrexone is not dangerous. And it can't be instead of something that I know works. So if you tell me that you want to take LDN instead of a disease-modifying therapy, I'm not okay with that. But if you tell me that you want to take LDN as a supplement in addition to a disease-modifying therapy, I'm okay with that. I can't tell you it's going to help you, but I don't think it's going to hurt you. And so under those circumstances, I don't think it's a bad idea. The next question from Darla. How often should people with MS include their cervical spine in the regular MRI? It's been a few years since I've had one. Darla, it's great to see you today. I hope that you're doing well. I hope that your kids are doing well. And let's talk about spinal cord MRIs. The diagnosis of MS, I think that we should get a brain MRI and a cervical spine, and probably a thoracic spine MRI. And the consortium of MS centers, of which my center is a member, recommends getting a brain MRI about once a year for monitoring. It recommends getting a spine MRI only when there are symptoms attributable to the spinal cord. As such, you wouldn't get one on a routine basis. Now, to talk about that for a second, there's a reason. You can have a brain lesion and not know it. In fact, most brain lesions occur without experiencing symptoms. However, in the spinal cord, it's very, very challenging to have a brain lesion without being, it's very challenging to have a spinal cord lesion without being aware of it. The spinal cord is about as thick as my two fingers. It's really thin. And all the information from the brain is funneled down into this thin spinal cord. And so if there's a lesion there, it typically doesn't go unnoticed. Therefore, it's not recommended that you get a screening C-spine every single year. Now, that being said, it is reasonable to get a C-spine MRI every once in a while. So Darla, if you haven't had a C-spine in a couple of years, I recommend that you reach out to the provider and say, hey, the next time we get an MRI, it's been a couple of years, can we throw in a C-spine? And I think that's a very reasonable thing to do. I don't think it's reasonable to get one every single year, but getting one every couple of years is probably a decent idea. So Cheryl writes in, hi from Fort St. John, British Columbia, Canada. I'd love to hear your thoughts on aggressive MS. How do you treat it? How do you diagnose it? What's the time frame for calling it aggressive? That's a great question. One of my very first papers I wrote when I was a fellow was on the treatment of aggressive multiple sclerosis. That was a paper that I published with my mentor, Omar Khan, in Lancet. And it was really an adventure studying and understanding aggressive MS. Aggressive MS, in my mind, is multiple sclerosis where we're having frequent MS attacks, and we're not recovering from attacks, and we're developing lots of new spots in the MRI. We're having breakthrough disease despite taking MS medicines. We're accruing disability at a faster pace than expected. There are certain risk profiles that increase the likelihood of having a more aggressive disease course. Diagnosed after 40, being a male, being non-Caucasian, having spinal cord disease, having 2 attacks within the first year, not recovering from your attack, having spinal cord, I said that already, having motor deficits, having sphincter involvement, having base of the brain involvement, having cerebellar involvement. There's a lot of things that go into clarifying someone as aggressive. And when they have aggressive MS, they're at risk of getting worse faster. And so I think that means that we need to be aggressive. Many of you know that I dislike the escalation model. I don't like the idea of starting someone on an easy breezy CoverGirl low efficacy drug that's safe and then seeing how they do. Because I think all too often the answer is they don't do well and we allow them to accrue brain damage before we escalate. Now, I don't like that for any patient with MS, but I particularly don't like it with people with aggressive MS. And in my strong opinion, if you have aggressive MS, we have to come out of the box swinging. We have to come out of the gate full on. And we have to use the most effective medicine as quickly as possible. Sometimes we initiate things with chemotherapy, such as cyclophosphamide or Lemtrada or things like that. Now, it's been 48 minutes. I've got 121 people online. I've got 112 thumbs up. This has been fantastic. I have a meeting that I need to get ready for, and so I'm going to have to get off of line. I am going to come back online, guys. Look for me multiple times this month. I assure you that I will be back online at some weird hour this weekend. My name is Aaron Boster, and thank you for learning about MS with me. It is MS Awareness Month, and it is incumbent on people impacted by MS to help raise the level of awareness, to help people understand what's up with this invisible illness and what we can do to fight back. Until my next video or my next live stream, this is Aaron Boster saying, take care.